Good morning, everyone. I'm Kimberly Chalia with PHCA. Thanks so much for joining us for today's webinar, Part 3, Nursing Facility Requirements of Participation, Phase 3, How to Survive the New Normal, presented by Paula Sanders. A few quick updates to share before we get started today. The webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1.5 continuing education credits for all attendees. For those who provided a NAB number, credits will be uploaded shortly, and we'll also share certificates with those in attendance. As we begin today, all attendees will be in listen-only mode. Please feel free to submit your questions via the Q&A icon on your screen, and we'll make sure to answer as many of those questions as possible at the end of today's presentation. And now I'll turn it over to Paula.
Thanks, Kim, and good morning, everybody. For those of you who have stuck with us, this is the third in a 3-part series on the requirements of participation. If this is your first time with us, the other 2 webinars that we've given on the RoP 3 guidance will be available on the PHCA website. In that convention, we will be giving an overview of the key points. And I'd ask you now, just keep in mind, if there are certain aspects that you would like to see covered about the RoPs at convention, shoot me an email by tomorrow, and I'll try and include those topics for you. So before we turn to the RoPs, let me give you breaking news that just came out this morning. CMS has extended the waiver for temporary nurse aides to get certified. They released a QSO, which is their new memos, late yesterday. CMS is going to authorize 2 types of waiver requests, one for individual facility waivers, and the second for statewide or county waivers. I fully expect that Pennsylvania will be submitting a statewide waiver request given the backlogs we've encountered. So sit tight. I don't try to submit one on your own yet. Let's wait and see if the Department of Health does apply for a statewide waiver. The waivers will be time limited, and CMS does expect the state agencies to actively work towards resolving the barriers to certifications. The waivers cannot and will not exceed the duration of the public health emergency, but this certainly will get us beyond the early October deadline. So like I said, breaking news, stay tuned and we'll see what the Department of Health does. I'm sure you'll be getting updates from Zach and the folks at PHCA. So now let's focus on the topics we're going to talk about today. They're sort of lumped in no particular order other than the order in which they appear in the State Operations Manual and the regulations. We're going to talk first about changes that CMS made to food and nutrition services. Then I want to spend a little bit of time talking to you about binding arbitration agreements, if any of you are using those. And there were some significant changes made to the infection control tags. In addition, the compliance and ethics program requirements are now in effect. And we'll talk very briefly about some modifications that were made to the physical environment. And then we'll conclude by talking about the new training requirements at 483.95. So let's talk first about the changes they made to food and nutrition services, which is F812. They recognized that there was some confusion in the earlier guidance between food distribution and food service operations. So they decided to separate them out, which I think will give greater clarity. Food distribution are the processes involved in getting food to the resident. And food service is the processes involved in actively serving food to residents. When actively serving residents in the dining room or outside a residence room where trained staff are serving food or beverage choices directly from a mobile food cart or steam table, there's no need to cover the food. So if it's active serving is going on, food does not need to be covered. Food does need to be covered, however, when it's traveling a distance, for instance, going down a hallway or to a different unit or a different floor. In addition, CMS has clarified hair restraint requirements. The food service staff have to wear hairnets when they're cooking, preparing, or assembling food, such as when they're stirring pots or putting vegetables together to assemble salads. Hairnets are not necessary when distributing food or assisting residents to dine. And if you have there's some organizations that have country kitchens, and the surveyors would frequently be citing staff who were serving but going into the kitchen to pick up food to be delivered. And this does certainly help clarify that, right? So a hairnet's on if cooking, preparing, or assembling, but not necessary if distributing food or helping residents to dine. CMS has also given a little bit better guidance on gloves. And obviously, this guy here, he'd get a deficiency under 812. He'd probably also get a deficiency under 880 for infection control, because I don't see gloves, although I do see wonderful loaves of French baguettes. So staff always has to wear gloves if they're preparing food, or they're touching ready-to-eat food, or if they're serving residents who are on transmission-based precautions. And that new piece down at the bottom there for residents who are on transmission-based precautions is something that people have been forgetting in the midst of the COVID pandemic. So minor changes for food services, but certainly something we wanted to touch on with you. Now let's talk about the interpretations and implementation of the regulations for binding arbitration agreements. This discussion is relevant for any arbitration agreement that was signed with an effective date on or after September 16, 2019. So if you have some old arbitration agreements that go back to September 16 of 2019, you want to pay attention and go back and examine what you have and what you're using right now, because you may not be in compliance. The binding arbitration cannot be a condition of admission or continued stay at the facility. Not only can't you make that a condition, but you have to explicitly have language in the agreement so that you're telling them in writing that binding arbitration is not a condition of admission or continued stay. And the CMS is addressing both conditions of admission, so that would be for a pre-dispute arbitration agreement. In other words, you're getting the resident and their family to sign an agreement to arbitrate even though nothing has happened yet. The continued stay language refers more to post-dispute arbitration agreements. In other words, something's happened and now you want them to sign to agree to arbitration. You have to inform the resident and their responsible representative that they're not required to sign. The arbitration agreement has to be in a form and in a language that the resident and their representative understands. The resident or the representative has to acknowledge that they understand what they're signing and the elements of the binding arbitration. Importantly, they have to have a 30-day right of rescission. A lot of earlier arbitration agreements only gave a 7-day right of rescission. So again, that's something I would go back and check to see if you have any old arbitration agreements that mention something less than 30 days. The arbitration agreement cannot contain any language that prohibits or discourages the resident or anyone else on their behalf from communicating with federal, state, or local officials, including but not limited to federal and state surveyors, other federal or state health department employees, and representatives of the Office of the State Long-Term Care Ombudsman. There's a lot of language in the State Operations Manual about this particular provision, but I don't think I've ever seen in Pennsylvania an arbitration agreement that prohibited or discouraged anyone from communicating with federal, state, or local officials. Now, if you have arbitration agreements, I want to give you some idea of what the surveyors are going to be told and what they're going to be looking at. First, they're going to verify through interview and record review that the resident or their representative understood what they were signing. Seems to me it's a little overreach on the part of the surveyors, because the arbitration agreement is never implemented. What are they proving? And the other piece, which is troubling to me from a litigation standpoint, is that the surveyors are being told in situations where the resident may have cognitive impairment, they should refer to the medical record to identify the resident's healthcare decision-making capacity at the time the agreement was offered, explained, and entered into. So you've got the surveyors looking at competency issues related to the ability to sign a binding arbitration agreement. A lot more detail here than there is, for instance, in determining a resident's capacity to consent to a sexual relationship. Additionally, surveyors are being told that they should thoroughly investigate the basis for the transfer or discharge for any resident who refused to enter into a binding arbitration agreement and has been or will be subsequently transferred or discharged. I want to spend some time taking you into the minds of the surveyors and the significance with which CMS is looking at these binding arbitration agreements. If you have a resident or representative who signed an arbitration agreement, they may get selected, and these are the kinds of questions they're going to be asked. What's your understanding of the arbitration process when a dispute arises? Do you understand that you are giving up your right to litigation in a court proceeding? Were you told that the facility could not require you to enter into an arbitration agreement in order to be admitted or in order to remain in the facility? Were you told that you had the right to terminate or withdraw from the agreement within 30 days? If yes, were you told how to do so? Did you feel you were obligated, required, forced, or pressured to sign the binding arbitration agreement? If yes, how so? Have you filed any complaints or grievances with the facility and/or state agency about the arbitration agreement? Is there anything you would like to have known before signing the arbitration agreement? Was the arbitration agreement explained in a way that you understood? If the arbitration agreement was included within another document, were you told first that you had the right to decline the agreement, and second, how to exercise this right, for instance, crossing it out, etc.? You might want to sit down with your admissions team and draw up an FAQ for your residents and resident representatives that explains the answers to these questions, so you can have proof in your file. I would give them a copy and keep a copy in the record that shows that they were told all of these things. It would be really helpful, because I have the impression, just in reading some of the ways these questions are written, that this is an area that will be seeing some increased scrutiny once the phase 3 RoPs are in effect, and once the surveyors start to get a feel on, under their belt of what these things look like. In addition to interviewing the residents and the resident representatives who have signed arbitration agreements, if your facility uses arbitration agreements, the surveyors are going to interview resident council and family council representatives. They're going to ask whether resident council has voiced any concerns to the facility about arbitration agreements, such as the way they're explained, pressured, or being forced into signing them, or concerns with the process for withdrawing or terminating an agreement. And this one is, think about a loaded question. Do you know if residents feel forced or coerced to sign the arbitration agreement? If yes, how so? So here we're getting into legally what would be called hearsay. Hey, tell me what else you know about somebody. And then the last question, who from the facility discusses or reviews the binding arbitration agreement with residents or their representatives? Not something I would expect resident council or family council to know. But importantly, we do know what CMS is likely to have the surveyors ask your staff. So for staff who are involved in getting and presenting arbitration agreements to your incoming residents, I would take this slide and prep them. Put this as part of your mock survey if you're doing mock surveys, or just make sure periodically you're talking to your key staff who work in this area. When and under what circumstances do you request that a resident or his or her representative agree to an arbitration agreement? How do you ensure that they understand the terms of the agreement? How do you ensure that the arbitration agreement is explained in a form and manner that accommodates the resident or his or her representative's needs? How do you make sure they understand the rights, such as their right to refuse to enter it and their right to rescind it within 30 days? What's your process for allowing residents or their representatives to terminate or withdraw from an arbitration agreement in the first 30 days? Do you know any residents who you've refused to admit or who were discharged because they refused to sign a binding arbitration agreement? Have any residents filed a complaint or grievance with the facility regarding the use of an arbitration agreement? And this last one, real critical from a liability standpoint, how do you determine if the resident's physical condition and his cognitive status may be contributing factors in understanding the binding arbitration agreement, including their ability to make an informed and appropriate decision? That's a real tough one, but it harks back, go back 2 slides, with the surveyors being told that if there's a situation where the resident may have cognitive impairment, the surveyors are going to be looking at the medical record to identify the resident's healthcare decision-making capacity at the time the agreement was offered, explained, and entered into. And now they're asking your staff how to determine if the cognitive status might have been a contributing factor. If you are using binding arbitration agreements to help reduce risk, you may want to confer with your defense counsel or your insurance carrier preemptively, because we still have time, right? These regulations aren't going to be surveyed until October 24th. So you have some time to figure out if there's a best way to be responding to these kinds of questions, since I fully expect them to be a focal point of your surveys if you're using binding arbitration agreements. Having reviewed that, we're going to jump to the changes in the infection control tags. And they're in 4 primary areas: the infection prevention and control programs, antibiotic stewardship programs, the infection preventionist qualifications and role, and flu and pneumonia immunizations. So let's turn first to what have they added on to F880? Water management requirements. You're going to have to be able to demonstrate measures you take to minimize the risk of Legionella and other opportunistic waterborne pathogen outbreaks in your building water systems. That means you have to implement a documented water management program using nationally accepted standards to minimize the risk of waterborne pathogens. Elements of your water management program should include an assessment of your water system to identify where opportunistic waterborne pathogens could grow and spread. Implementation of measures to prevent the growth of opportunistic waterborne pathogens, also known and referred to as control measures. And that could include visible inspections, using disinfectants, and/or temperature controls that may require mixing valves to prevent scalding. You want to make sure you're documenting the monitoring plan of your control measures and that your testing protocols for control measures, acceptable ranges of control measures, and documenting the results of testing, and establishing ways to intervene when your control limits are not met. Some of the new probes under F880 related to water management include, were there any diagnosed cases of Legionella in residents since the last recertification survey? Did the facility implement adequate prevention and control measures prior to and once the issue was identified? Where we see this happening a lot is you may have a resident who is at the hospital and is diagnosed with Legionella, and it somehow comes back to a suspected contraction at your facility. States are directed to work with their local, state, and public health authorities, if possible, to determine if water management was inadequate to prevent the growth of Legionella or other opportunistic waterborne pathogens, and whether the facility implemented adequate prevention and control measures once the issue was identified. And I would urge you to consult with experts in this field to make sure you do have a program in place. And one of the reasons I want you to do that is because they have placed this under F880 for infection control. And you may recall that F880 is one of the few F tags that has its own separate enforcement mechanism. So under F880, if you're out of compliance, the state can impose a directed plan of correction called a DPOC, which you have to implement. It's a directed plan from the state that you have to implement, and you have to communicate directly with your field office about the implementation of the DPOC, Directed Plan of Correction. In addition, depending on the scope and severity of the F880 infection control tag and your prior history under F880, you may find yourself with a discretionary denial of payment for new admissions that starts as soon as, in the most serious cases of immediate jeopardy, 15 days after the receipt of the 2567. You have 15 days to get back into compliance. It ranges from 15 days to 45 days. And this is different. This discretionary denial of payment for new admissions is different from the mandatory denial of payment for new admissions. A mandatory denial of payment for new admissions is what we're used to, right? You're not in compliance 90 days into your survey calendar, you're going to get a denial of payment. This discretionary denial of payment related to the F880 tags goes into effect in whatever time period is set forth in the letter from the state based on your prior history and the scope and severity of the F880 tag. And you don't get additional notice. The only notice you'll get is in the letter from the Department of Health. Additionally, if you're cited for F880 and you have any other open tags, even if you correct the 880 deficiency, that discretionary denial of payment will continue until you're back in substantial compliance with all tags. Even if the state came back on a revisit and said, oh, great job, you cleaned up that F880 infection control deficiency, but now you're out of compliance with food service, that F880 DDPNA is going to continue even though your deficiency was corrected. So critically important that you pay attention to this new element of F880 and make sure you have a water management plan in place. Let's turn now to changes that that CMS made to the Antibiotic Stewardship Program, or the ASP. They removed the requirement that you have to give feedback to the prescribing practitioners about their antibiotic stewardship, but they do recommend that you still give the feedback. And the issues they are expecting communication about are antibiotic resistance data, the prescriber's antibiotic use, and the prescriber's compliance with facility antibiotic use protocols. But you won't be cited if you don't do that. Note that the antibiotic orders must include the indication, the dose, and the duration. Well, the CMS has also noted that that surveyors weren't always consistently citing deficiencies related to the antibiotic stewardship and unnecessary antibiotics, your unnecessary drugs. So they did try to clarify that if there are concerns about the antibiotic stewardship program, the survey must include one resident on an antibiotic. And they're specifically to look at whether the residents are being prescribed unnecessary antibiotics and if there are any negative outcomes, in which case they're going to cite under F757. You will get cited under F881, the Antibiotic Stewardship Program, if you're not implementing part or all of the other required elements of the ASP. The CMS has also revised guidance regarding the infection preventionist under F882. The infection preventionist has to be responsible for an infection prevention and control program, your IPCP, and must physically work on site at the facility. They can't be a consultant at corporate. They have to be physically on site. If you can designate one or more people to be your IP. They have to be trained in nursing, medical technology, microbiology, epidemiology, or another related field. And you have to have documentation of their primary professional training. The number of hours that they work, they can be part-time, but you have to look at how it's supported by your facility assessment. Their hours should be determined based on the facility assessment, considering your census, the resident characteristics, complexity of the services offered. Additionally, the surveyors are going to assess whether your infection preventionist has sufficient time. Is she there or he there enough time in your building to properly assess, develop, implement, monitor, and manage your infection prevention and control program, address the training requirements, and participate on the QAA committee? Surveyors are going to ask the IP, they're supposed to interview them, to see if they think they have adequate time to perform the role. They're also going to interview the infection preventionist and staff to see where work is performed. Now, if you haven't already asked your IP if he or she feels they have adequate time to perform the role, you may want to be sort of proactive and see what else it is that he or she thinks they may need. Because I expect the surveyors to ask, especially if you have problems with other areas of infection control. The infection preventionist has to obtain additional specialized infection prevention control training through one or more courses, and you have to have evidence that they've completed that training. So they're going to have to give you some sort of certificate of completion or an equivalent. Note that CMS and CDC have joined forces to create a free online training called the Nursing Home Infection Preventionist Training Course. There's a link when you get the slides, you'll have that. You may want to have your infection preventionist complete that, because that'll give you the certificate to put in their file that they were trained off of the recommended program. They're not required to do it, but it's free. And there won't be questions raised about the content, because this is a CMS CDC training course. The infection preventionist also has to be a member and report, a member of the QAA, the Quality Assurance Committee. They have to be a member, and they have to report on the infection prevention control program and incidents. And those things should include healthcare associated infections, the facility process and outcome surveillance, occupational communicable diseases such as the flu, and the antibiotic stewardship program related to antibiotic use and resistance data. The infection preventionist or designee must attend each QAA meeting. With respect to their participation on the QAA committee, if there's a deficiency, it's going to be cited under the QAPI tag, under the QAPI tag at F868. So when you think about who your infection preventionists are, and you can have more than one, if you have questions about their primary education, I would direct you to look at the state operations manual, because they go into much more detail about the underlying primary degrees that are acceptable. Anyone who you are going to use as your IP or IP designee should have a corresponding job description that supports the roles that they're supposed to be fulfilling, in case the surveyors are asking about that, so that you can show that you have sufficient coverage. Additionally, CMS revised the immunization for flu and pneumonia immunizations. They removed some outdated language and gave more flexibility to clarify that facilities should follow the CDC and the Advisory Committee on Immunization Practices on the recommendations for vaccines, right? Now, we're coming into flu and pneumonia vaccination season. What I have here in red is a direct quote out of the State Operations Manual. A nursing home may encounter residents who do not have adequate documentation of vaccinations. With the exception of flu vaccine and pneumonia vaccine, the PSV, providers should only accept written, dated records as evidence of vaccination. Now, this is significant. Self-reported doses of influenza vaccine and PPSV are acceptable. A resident representative can report on behalf of the resident if he or she is unable to self-report and the representative has knowledge of the resident's medical care. State laws may have more stringent requirements related to documentation. I put this here because we've seen over the years facilities getting cited under federal tags for not having written documentation of flu and PPSV vaccinations. All they've had are a verbal report. So I raised that for you. You've got it here. You should be able to find it in the State Operations Manual if you get cited. The other piece, though, that keep in mind is if it's not documented, it didn't happen. So you've got to have some sort of documentation in their records about the education you've given to the resident and or their representatives about the risks and benefits of the flu and pneumonia vaccines, and document both that you've given that education and especially if they've refused to get vaccinated. If you don't have documentation that you educated them, you are very likely to get deficiency. So that takes us now through infection control. Let's talk about the compliance and ethics program. This has been kicking around since the regs came out. It's actually been kicking around much longer than that. When the Affordable Care Act was first passed, CMS was directed to make sure that nursing homes had compliance and ethics programs. In the State Operations Manual, which is why this is in red and in quotes, CMS has said that the intent is to ensure that facilities have in operation an effective compliance and ethics program that uses internal controls to more efficiently monitor adherence to applicable statutes, regulations, and program requirements to deter criminal, civil, and administrative violations under the Social Security Act and promote quality of care for nursing home residents. So you could see the intent is not just focused on billing. It's also focused and inspected to address statutes, regulations, program requirements, which is a loosey-goosey legal word, right? It's not a law, it's not a regulation, it's a sort of a requirement, and to promote quality of care. I don't know how many of you have compliance programs in place. I know early, I want to say it's almost probably the last decade when everyone was rushing to make sure they had compliance and ethics programs in place. And then when their regs didn't come out, then they came out, but they weren't being enforced. Then we had no guidance. Well, people just put us on the shelf someplace. Time to dust them off. We could do a whole training for at least, I would say, 45 minutes, speaking solely on compliance and ethics programs. So right now what I want to do is give you a high-level overview so you can assess whether you're going to need further help in getting your program kick-started sufficiently enough to pass a survey. Now, in the State Operations Manual, you'll see that CMS discusses the Office of Inspector General Compliance Program Guidance, the CPG, and the elements. For whatever reason, and I can't quite figure it out, but it's not surprising because I often don't understand why CMS does or doesn't do things. They did not adopt the OIG compliance program guidance. They instead tinkered with it. What I will tell you is, in my opinion, if you're meeting the requirements of the OIG program, you will easily meet the CMS requirements. The converse is not true. If you meet the CMS requirements and you get in trouble with the feds, with the Department of Justice and the Office of Inspector General, this CMS regulatory requirement is not as robust as what the Office of Inspector General will require. So if you've got a choice, you may want to set your program to the OIG standards. That's probably what I would do if I'm pretty far along. But if you're just starting and you're sitting there saying, what the heck is a CEP? Let's stick with the minimum that CMS requires to get you through survey, right? Because CMS is only surveying you to see if you meet these requirements for purposes of Medicare certification. The OIG and the Department of Justice, on the other hand, if they're evaluating your compliance program, it's because they have concerns about your operations, whether from a quality standpoint, a billing standpoint, or a combination of both. So let's look at the CMS compliance ethics program elements. Written standards, policies, and procedures. High-level personnel oversight. Sufficient resources and authority. Delegation of substantial discretionary authority. Effectively communicating program standards, policies, and procedures. Taking reasonable steps to achieve program compliance. Consistent enforcement through disciplinary mechanisms. Response, what's your response to detected violations, and an annual review of your program. Not a lot of heavy lifting there when you look at the OIG program elements. Now, this is if you are in an organization that has 4 or fewer facilities. There are additional compliance and ethics program elements for organizations that have 5 or more facilities. If you've got 5 or more facilities, you have to have mandatory annual training. You have to have a designated compliance officer for whom the compliance and ethics program is a quote unquote major responsibility. The compliance officer has to have sufficient time and resources, and they should be able to communicate with the governing body without being unduly subject to coercion or intimidation, to ensure they're not unduly influenced by the general counsel, CFO, or CEO. Let me pause here because at one point, the CMS had proposed that the compliance officer could not report to the general counsel, CFO, or CEO. And now they're just saying they want to make sure if you're in an organization with 5 or more facilities, your compliance officer can communicate with the governing body without being subject to coercion or intimidation. So they loosened up a little bit of that. You're also going to have a designated compliance liaison at each facility, but that's only if you have 5 or more facilities in your organization. So how are you going to assess where you're at? Again, I think it's pretty easy to step back and let's look at the probes. What are the surveyors going to be looking at immediately to determine if you have an effective compliance and ethics program? They're going to look at the following things. Does the operating organization have written standards, policies, and procedures for the CEP that are reasonably capable of reducing the possibility of criminal, civil, and administrative violations under the Act? What do your policies and procedures look like? Pretty easy to do a review to check your compliance if you have them even, right? Now, this is starting October 24th. They are going to interview high-level personnel who was designated by your governing body to oversee the program. And they're going to interview that high-level personnel to determine their involvement, to determine how the facility uses monitoring and auditing systems to detect civil, criminal, and administrative violations by staff. They're also going to ask if they're aware of any potential violation under investigation and what was their response. Low-hanging fruit from my perspective, this is this next one. They're going to ask staff, are you aware of the facility's compliance and ethics program? Do you have a method to anonymously report suspected violations? This is a big one, guys, right? You have to have an anonymous reporting system. Having people call a hotline in the compliance officer's office that's answered by your staff is not going to qualify here. You have to give them a way to make anonymous reports. A lot of folks don't have that right now. They're also going to ask staff if they're confident in reporting compliance matters without fear of retaliation. If you can't answer those questions, you're in trouble, right? That means we need to get going on jumpstarting our compliance program. If you were subject to an OIG corporate integrity agreement, one of the things that the OIG monitors are asked when they go into buildings is, do you know the name of the compliance officer? Here, we're not at that high level. That's what I meant. This is like baby compliance compared to the OIG compliance. Additionally, the surveyors, when they're looking to determine your compliance with this compliance and ethics program requirement, they're going to look to see if there were reports or reasonable suspicions of violations that were identified. Did your organization take prompt action to respond to the violation and to fix it to prevent future occurrences, including enforcement of the program standards, policies, and procedures through disciplinary mechanisms if appropriate? Did the operating organization delegate substantial discretionary authority to an individual it knew or should have known through due diligence had a propensity to engage in criminal, civil, and/or administrative violations? Does the operating organization review the program annually? and as needed in response to organization, facility, and/or regulatory changes. And if you are in an operating organization that has 5 or more facilities, has there been a compliance officer and a facility-based compliance liaison designated? They're also going to look if you've got 5 or more facilities, if you've provided mandatory annual training on the compliance and ethics program. Note that you are not required to provide annual training if you on compliance if you have less than 5 facilities. Now, there's a lot to unpack here, certainly more than we have time to do today, because now we're going to talk to changes that they've made in the physical environment tag, right, under 483.90. Main focus here on bedrooms and call bells. The resident call system has to be adequately equipped to allow residents to call for staff through a communication system which relays the call directly to a staff member or to a centralized staff work area from each resident's bedside and at each toilet, bath, and shower. And the communication device, or the call bell, should be accessible to a resident lying on the floor, which is why I put this picture here. I thought you could use it in training. I worry about how you're going to comply with that accessible to the resident lying on the floor. In this picture, if I fell brushing my teeth, maybe, and landed on the floor, the call bell would be accessible to me. But suppose I fell backwards and the call bell was closer to the wall, but still low to the floor, so arguably a resident could pick it up. I just don't understand what that language means, frankly. So something to keep in mind. I think ultimately what it means, it always hurts my head to say this, right? But a lot of the bathroom call bells are on strings or pulleys or ropes or something that don't go all the way down to the floor. I would suggest that you make sure that you have at 2 heights, right? One that's accessible sort of at the level with the toilet, level with the bath and shower, and then one also that would be lower to the ground in case a resident has fallen and they can't reach up to grab the call bell. But just keep an eye on that picture because that may help you in your analysis here. The cue to the surveyors goes beyond this though. Residents and their representatives should be interviewed about whether call bells are being answered. For instance, do you have access to your call light at all times while you are in your room, bathroom, or shower? Well, 2 different things right there, right? Interviewing about whether call bells are being answered is different from whether you have access to your call light. And if you recall from our discussion on the last webinar, where CMS has gone really much farther into the weeds on the psychosocial harm that is imputed when call bells aren't being answered timely. So I see this getting all connected, right? You want to make sure you're testing and ensuring the ongoing operability of your call system. You can use a wireless system for residents to call staff members directly. And remember, there's this push to home-like environments, so loud bells and things are being discouraged. And then I've already mentioned this, but this ties into that whole timeliness, right? So we've got this slight modification on the physical environment of where your call systems are located and where your devices are. But then don't lose sight of the fact when you're talking to staff about this, that whole element of psychosocial harm that takes you light years beyond just not having a functioning call bell system. So keep that in mind as you're looking at this issue. Additionally, bedrooms. Bedrooms in facilities that receive approval of construction or reconstruction plans by state and local officials or are newly certified after November 2016 have to accommodate no more than 2 residents, while older facilities can have up to 4 residents. That didn't change. However, CMS is now urging providers to consider making changes to their physical environment to allow for a maximum of double occupancy in each room. Additionally, we encourage facilities to explore ways in which they can allow for more single occupancy rooms for residents. So I think we're going to continue to see a push from CMS to move away from, certainly from wards, but really trying to look as much as possible to single occupancy rooms. Now that's it for physical plants. And we're going to wind up our discussion today talking about the new training requirements. And we're only going to talk about those requirements that have been added or made effective or refined. This is not the full list of training requirements. There are some changes to the general language. Then we're going to talk about effective communication training, residents' rights training, training about your QAPI program, infection control training, compliance and ethics, in-service training for nurse aides, and behavioral health training. And I apologize for that typo there on nurse aides. So the general requirements. They expect your training needs to be based on your facility assessment. And throughout the state operations manual, we're seeing an increasing reference to the expectation that you're using your facility assessment as a living, breathing document. Well, I'm going to talk about that at convention. We don't have time to really go into depth about how this threads through just about everything. They expect you to have competencies and skill sets done for all new and existing staff, individuals providing services under a contractual arrangement, and volunteers consistent with their expected roles. We're starting to see deficiencies already increasing because folks don't have proof that their contracted staff have demonstrated competencies and skill sets. Something you may want to review with any agencies that you have contracts with to make sure you have access to their competencies and skill sets if they're done by the agency. You should make sure that you keep a record of all your trainings, and the general training requirements should be met before staff and volunteers independently provide services to residents annually and as necessary based on the facility assessment. Ways in which your facility assessment should indicate and may inform the need for additional training topics. Look at this list: advanced care planning, cultural competencies, end-of-life care, geriatrics and gerontology, substance abuse, working with young and middle-aged adults if that's a population that you're targeting or admitting, grief and loss, interdisciplinary collaboration, person-centered care, special rehabilitative therapy, trauma-informed care, intellectual disability, mental disorder, quality of life, and care. Now, this is on top of what we're going to start talking about next. This is looking at your facility assessment to see if any of these other items should be incorporated into your annual training programs. So we have a new FTAG, 941. Mandatory effective communication training for direct care staff. Now, interestingly, this definition of direct care staff is much broader than when we otherwise talk about direct care, right? These are individuals who, through interpersonal contact with residents or resident care management, provide care and services to allow residents to attain or maintain the highest practicable physical, mental, and psychosocial well-being. We're not talking about AIDS here. We're talking about a really broad category of folks. And we're looking at their ability to communicate effectively with staff, as well as with the residents. If you have residents who use devices to help them speak or have different languages or cultural issues, that's going to be included in this communication training. Those training topics should reflect the needs of the resident population and the needs of staff and correspond with your facility assessment. So if you've got staff for whom English is not a primary language, you're going to have to change the kind of training that you're giving to comply with 941, because that effective communication goes in two directions. So don't just look at your resident needs. We also have to be looking at the needs of staff to make sure the communication training is understandable and relatable. We have next 942, residents' rights training. Who needs to be trained? All facility staff, direct and indirect care functions, contracted staff, and volunteers with training topics as appropriate to the role. In each one of these training tags, you need to go in and say, well, who falls under this rubric, right? Here we're talking about direct and indirect care functions. When we were talking about mandatory effective communications, that was direct care staff, right? So we're going from direct care to direct and indirect for all my staff, contracted staff and volunteers. Your training program for residents' rights should support the current scope and standards of practice through curricula which incorporates learning objectives, performance standards, and evaluation criteria. That's fairly standard through a lot of these training requirements. And that just means you can't just throw out a sheet of paper and it says follow resident rights, right? They're looking to see that you have a curriculum, that there's a program, that you have learning objectives, performance standards, and evaluation criteria. Staff performance and assessments should evaluate the ability to integrate knowledge and skills specific to resident rights. And you've got to have a process to validate that the training was completed, whether in a group setting or an individual basis. 942 goes into a bit more detail in terms of what's required under the resident rights training, but it pretty much follows the resident rights regulations here. More detailed, however, is the training that's required on your QA/PI program. Staff includes all new and existing facility staff with direct and indirect care functions, individuals providing services under a contractual arrangement, and volunteers consistent with the volunteers' expected roles. Note that here we're talking about new staff, which means before your staff starts, right, you can get all of your existing folks under an annual training, but new people coming in are expected to be trained. What are you supposed to train on? The goals and elements of your QA/PI program. How is your QA/PI program being implemented? What's their role, the staff's role in the QA/PI program? You got to train them how to communicate concerns, problems, or opportunities for improvement to the QAA committee. And you have to update and retrain whenever the QA/PI program or its goals are updated. And this, again, is the training has to support the current scope and standards of practice through curricula which detail learning objectives, performance standards, and evaluation criteria. And then you have to have a tracking system to make sure that staff have been educated. So again, a very formal training program with respect to this QA/PI element. 945, new training requirements for infection control. You have to train on the standards, policies, and procedures for your infection control program. It must be appropriate and effective and as determined by staff need. So what does that mean? Well, if I'm training and I'm telling staff they have to wash their hands, and I go through that entire hand washing program, and I'm walking down the hall and I have staff who's not washing their hands, my training is not effective. I've got to retrain, right? So the topic has to be appropriate, but it also, the training has to be effective. Staff includes all facility staff, direct and indirect care functions, contracted staff, and volunteers. It's pretty much, you know, you're coming in my building, you pretty much need to know about infection control if you're doing anything in the building here, including contracted staff and volunteers. I have to revise my training program, my infection control training program. If there are changes in my resident population, if there's changes in the community infection rate, if national standards change, if there's a lot of staff turnover, if my physical environment changes, or there's changes in my facility assessment that affect my infection control prevention program. So a lot to absorb here, right? This is one of those areas where they expect to see revisions in the training all the time. You know, you guys got to be on top of this, and goes back to the question that surveyors are going to be asking your infection preventionist. Do you have enough time to do the training, right? And if they're not the trainer, I expect them to have a role in developing my infection control training program. What are some of the mandatory topics? For the facility surveillance system designed to identify possible communicable diseases or infections before they can spread to other persons in the facility. When and to whom possible incidents of communicable disease or infections in the facility should be reported. how and when to use standard precautions, including proper hand hygiene practices and environmental cleaning and disinfection practices. How and when to use transmission-based precautions for a resident, including but not limited to the type and its duration of use depending upon the infectious agents or organisms involved. Occupational health policies, including the circumstances under which the facility must enforce work restrictions and when to self-report illness or exposures to potentially infectious materials. Proper infection prevention and control practices when performing resident care activities as it pertains to staff roles, responsibilities, and situations. You want to include in here as well, although CMS doesn't, under the occupational health policies, your OSHA requirements relating to a written respiratory protection plan, because that includes a whole nother series of infection control training. Now, if there are concerns about infection control in the facility, these are some of the probes. It's going to tie us back to 880. Did staff observations or did interviews with residents and or the resident representatives indicate a training need? Did staff report not receiving training about the concern identified by the surveyor? What process does the facility have to encourage staff to express concerns and request training in challenging situations? Does the facility respond to staff's concerns and requests for training? Review the training coursework to determine if the content meets professional standards and guidelines and covers facility policy and procedures for infection prevention and control, right? Review the training coursework. Again, this is a very established training program that they're looking for. Does the facility implement the training program and ensure staff are instructed to meet the requirements of infection control F880? And here, make sure you're including the new requirements of water management. Verify that the facility has a mandatory requirement that all staff participate in infection prevention and control training with a process in place to track such participation. There's a very robust training program that they're expecting. That's in contrast to what we're looking for compliance and ethics training. Under F946, staff includes all new and existing staff, direct and indirect care functions, individuals providing services under a contractual arrangement, and volunteers. Note we're talking new and existing. That means new people coming in have to receive training. But for an operating organization, which is the individual or entity that operates a facility, they have to provide a training program or another practical manner to effectively communicate the standards, policies, and procedures of the compliance and ethics program to its entire staff. I don't need a formal training program if I have flyers or brochures or something else that's communicating the standards of my program, policies and procedures, standards, policies, and procedures. I can get that out in another way. However, if I'm an organization that has 5 or more facilities, I have to have an annual training program on compliance and ethics. Note that difference there. 5 or more annual training, 4 or less, a training program or another practical manner to effectively communicate the standards, policies, and procedures. Whatever training I do should support the current scope and standards of practice through curricula, which detail the learning objectives, performance standards, and evaluation criteria and can be tracked. Required in-service training for nurse aides. CMS makes clear that private duty nurse aides who are not employed or utilized by a facility on a contract, per diem, leased, or other basis are not required to take the service. They're not covered by this required in-service training if you're not using them to perform services. Performance reviews are defined as the process to evaluate the performance of staff on a periodic basis, which may be annually. You've got to develop, implement, and permanently maintain a nurse aid training program that's appropriate and effective. Again, effectiveness determined by the nurse aid performance reviews and the facility assessments. They expect you to do a variety of trainings, not just webinars, so that there's interaction. When able, each nurse aide should be evaluated based on his or her individual performance. And you should develop training that can be utilized and beneficial to all nurse aides when applicable. What that means is if you find somebody who's screwed up and you train them, you may want to go back out and train the whole lot of them, right? Develop training that you've identified an issue on somebody's performance that may be applicable to everybody else. All training, as we mentioned before, should support the standards of practice through curricula which detail learning objectives, performance standards, and evaluation criteria. But here, unlike a lot of the other new tags that we're talking about, they expect this training for the nurse aides to also address the potential risks to residents, staff, and volunteers if procedures are not followed. So 947 has been around for a while. What they've done is tweak some things here, but I did want to draw your attention to that distinction that we go and expect in this in-service training to talk about potential risks if procedures are not followed. Adequacy of the training has to be demonstrated by nurse aid competencies through written exam and or consistently applying interventions necessary to meet the resident needs as identified in your facility assessment. Now we're going to talk about the behavioral training. This is a new one, 949, who's covered all staff, direct and indirect care functions, contracted staff, and volunteers. Training topics as appropriate to the role. The training has to be appropriate and effective as determined by staff need and your facility assessment. Your training needs to be revised for changes to your resident population, staff turnover, physical environment, and modifications to your facility assessment. So like these other areas, we're looking at a dynamic training program. Training should support the current scope and standards of practice through curricula, which detail learning objectives, performance standards, and evaluation criteria, and can be tracked, right? They expect you to do that. What are some of the minimum competencies and skills? What are these minimum things that you've got to be training on under the behavioral health training? Person-centered care and services that reflect the resident's goals for care. Interpersonal communication that promotes mental and psychosocial well-being. Meaningful activities which promote engagement and positive, meaningful relationships. An environment and atmosphere that is conducive to mental and psychosocial well-being. Individualized, non-pharmacological approaches to care. Care specific to the individual needs of residents that are diagnosed with a mental, psychosocial, or substance use disorder, a history of trauma and or post-traumatic stress disorder, or other behavioral health conditions. And care specific to the individual needs of residents that are diagnosed with dementia. Those are the minimum elements of your training program, as determined by the facility assessment. I always think it's helpful, as I mentioned before, to look at what is it that the surveyors are going to be looking at, because that helps me understand if my program is going to pass muster. So here are just some of the probes. Does staff demonstrate the skills needed to promote the highest practicable level of functioning for residents with identified behavioral care needs? Can staff explain concepts learned in training? So they're going to take your training program. We're going to talk to the staff about it. Can they explain what they learned? How do you assure that all staff interacting with residents are trained as required? Note this next sentence. This may include nursing, therapy, activity, housekeeping, dietary staff, and others as needed. We're looking, again, this behavioral health training widespread. How do you assure that all facility staff, contractors, and volunteers are trained to interact with those with specific behavioral health care needs? Is your training program designed to address the residents' specific behavioral health care needs? How do you keep track of staff participation in required training? How are you monitoring the effectiveness of the training program? How are changes implemented into the training program if desired outcomes are not achieved? And is the training curriculum based on the results of the facility assessment? I'm going to leave you there with that lingering question about the facility assessment. We're going to pick up that theme at convention and talk about new expectations for the facility assessment as demonstrated in the requirements of participation phase 3. So keep something to look forward to if you're not already completely overwhelmed. The only positive note I can leave you with is, as new as this is to you, it's new to the surveyor. So I think we're going to have a bumpy couple of months, more likely a bumpy couple of years, as the state and federal surveyors try and get up to speed with this. And with that, Kim, I'd like to turn it over to questions if anybody has them.
Fantastic. Thanks, Paula. Yes, Paula, I see there's a couple of questions that came through. If you click on the Q&A icon on the bottom of your screen.
Will 757 be a focus now instead for C. diff increase versus 880? No. 747 might be in addition to 880. But we're going to be looking at the what elements trigger. And remember that we are seeing throughout the new requirements of participation guidance an increased emphasis on linking to additional tags, right? So I would not be surprised if you had a problem with C. diff that you might be getting an 880 for infection control if there was an infection control breakdown that led to the C. diff, as well as a 757 related to your other issues. So certainly something to look at. The next question, can I clarify the staffing requirements that the DON cannot work as a charge nurse? Kim, I'd like to pull up the state operations manual and see to respond back to that. So if it's okay with the person who posed that question, let me shoot you the answer in a few minutes, Kim, and then you can send that out to folks when you're making the PowerPoint available to them, if that works. I just don't want to answer that without double checking what the state operations manual says.
Okay, and then there was an additional question from an anonymous attendee. Are you going to go over the staffing changes?
I will do the staffing changes at convention.
All righty.
We only have 5 minutes left today.
All right, thanks, Paula. If there are no additional questions, we'll wrap this up today. I appreciate you taking the time, Paula, to go over all of this important information with us.
It was my pleasure. Everybody enjoy the last few weeks of summer. Thanks.
Thanks.
We'll see you at convention.
Bye.